Good evening, everyone, and very warm welcome to everyone, those who are in this room as well as online. I'm Dr. Priyam from the Medical Affairs team at MSD, and I welcome you all to the masterclass on cervical cancer, organized by the Indian Society of Oncology, supported by MSD. So the treatment of cervical cancer in the metastatic stage has evolved quite a bit over the recent few years with the advent of immunotherapy. And now we're looking into the treatment of earlier stages of cervical cancer with the use of immunotherapy. So, to begin the program, I invite upon the program director, esteemed medical oncologist, Dr. Ghanshyam Biswas, who is consultant medical oncologist and executive director at Sparsh Hospital in Bhubaneswar. So, welcome, sir.
So thank you, PM. So 5 minutes as the context setting. So master class on cervical cancer and why it is important. As she said, so organized by Indian Society of Oncology and MSD. I'm unable to see the slide. So if we look at the burden of cervical cancer, so 2020 Globocan, on my left hand side you can see the incidence, so 3.1%, so annual incidence globally, and look at the mortality. So again, 3.4% mortality in regards to globally, and this phenomenon is much more in our country. So China and India constitutes almost one third of the global cervical cancer burden. And India has the highest estimated number of cervical cancer deaths. So if you look at the WHO statistics, every minute one woman is diagnosed with a cervical cancer in the world, and every 7 minutes one Indian woman dies of a cervical cancer. So that's the sorry figure. Indian women face a 2.5% cumulative lifetime risk and 1.5% cumulative death risk from cervical cancer. So these are several risk factors, and you can see on the board is a human papilloma virus, and we are thankful to Government of India that there are vaccines available. So those who are in the crowd haven't taken the vaccines at the right age, so one should take this vaccine because this is one cancer where you can prevent with the available vaccine. So now the cancer miracle isn't a cure when you are talking about a cervical cancer, it's prevention. So cure is an erroneous target, cancer prevented is better than a cancer cured. So look at the extent of disease. So we talk about TNM and the figure staging. So if it is a carcinoma situ, then probably all these patients are going to be living. Then stage 1 is limited to cervix. To make it simple, stage 2 is extension to uterus, parametrium and vagina, because when somebody is not dealing with a organ specific, like most of us are a community medical oncologist, so you see today cervix, then tomorrow SCC, then stomach, then it's very difficult to remember everything, but broadly we should remember. So 1 is limited to cervix, 2 is extension to uterus, parametrium and vagina, and 3 is place. So stage 3 is extension to pelvic side wall and or lower third of vagina, and stage 4 is extension to adjacent organs or beyond true pelvis. So as we go down from in situ to stage 4B, you can see the survival from 100% is dropping to less than 20%. Even in a stage 4, there are 4A, which is adjacent organs, bladder and bowel, so which I will take over, and stage 4B are distant metastasis, which Dr. Saurabh will take over. And each stage will have A, B, and then A will have 1 and 2, and B 1 and 1 and 2. So to make it more simple, stage 0 means pre-cancer or carcinoma stage cervical cancer. Stage 2 is locally advanced cervical cancer. Stage 3 is an advanced cervical cancer, which again I will deal. Stage 4 is a metastatic cervical cancer to other organs like lung, liver, bone, so that Dr. Saurabh will take over. So broad principles of treatment for the standard teaching for last few decades has been depending on the stage. So surgery for quite a few patients, radiotherapy, which is the mainstay of treatment for many of our patients, and along with that there is a concurrent chemotherapy. Early stage, stage 1 and stage 2A surgery or RT alone, advanced stage, stage 2B and 3, concurrent chemoradiotherapy, and surgery means here a radical hysterectomy, radiotherapy here means an external radiotherapy plus brachytherapy over 6 to 7 weeks. So that has been the standard teaching. So now, we will deal today, 15th of May, so cervical cancer, which is the next talk by Dr. Saurabh, and I will deal with the early cervical cancer or the locally advanced cervical cancer. So over these last 3 decades or so, there are 6 practicing changes phase 3 trials in cervical cancer. Is adding pembrolizumab to the age-old current chemoradiation. So in the armamentarium for immune checkpoint inhibitors, so 4 immune checkpoint inhibitors in 5 phase 3 trials in the cervical cancers. So pembrolizumab is a PD-1 and the semipilimab is a PD-1, and we have 2 other PD-L1, that is durvalumab and atezolizumab. So as you know, so there will be 2 talks, one followed Dr. Saurabh followed by me. So Dr. Saurabh will talk on the role of immunotherapy in a metastatic cervical cancer, and I will talk on the role of immunotherapy in a locally advanced cervical cancer. So I hand on the baton to Dr. Saurabh.
So that topic for today for me is metastatic cervical cancer and the role of immunotherapy in it. So this data already has been presented. Cases are high, mortality is high, and the number of cases are also going to increase. What we have been doing in cervical cancer is that the main paradigm for treatment has been chemotherapy, of course with targeted therapy, that was bevacizumab, which came in 2017. Otherwise there had been not much of improvement in metastatic cervical cancer. The chemotherapy options which are there, you can see here bevacizumab, topotecan, vinorelbine, gemcitabine, all these options are there. With everything, this is in the second line, you get a response rate of up to 25%, which in fact is more, I would say. Rather, what we see in clinic, I mean in the real world, is something around 10 to 20% is what we would see, and the overall survival is also pretty low. So there is definitely an unmet need in this subset of patients. So this was a study. Okay, so the predominantly what we use now is based on these trials which were conducted. So we can just summarize this table by saying, compared to single agent cisplatin, which is the mainstay of treatment, a combination of cisplatin with paclitaxel would lead to an improvement in response rates, would lead to an improvement in survival also, progression free survival and overall survival, that we know. Then cisplatin has its own toxicity. So paclitaxel and carboplatin, if you compare them with paclitaxel and cisplatin, you have almost similar results. Toxicities are less with carboplatin. So now we are using paclicarbo. Some other regimens can also be combined with cisplatin, that includes either topotecan or vinorelbine. But if you compare all the four regimens, you can see there was a study which was done, and you would see that probably paclicis or paclicarbo is the best regimen with the best responses and more practical to use, and that is why we use this regimen routinely in our clinical practice. Tiwari et al., they presented this data, that was the GOG, which was a paradigm 2017 NEJM publication. They showed that addition of bevacizumab would lead to an improvement in progression-free survival as well as in overall survival. So this was the study which was presented, and therefore the standard then became pacli, carbo and bevacizumab. Many of these patients are not able to take bevacizumab because of multiple reasons. Bevacizumab has its own unique toxicity. Fistula is something which we should be very aware, very about in these sort of patients, because many of these patients have received prior chemoradiation, undergone surgery. So fistula because of bevacizumab could be a problem. Anyways, with the standard which we have now is pacli, carbo along with bevacizumab. Still, with that you would get a median overall survival of 17 months. So that is what was this study was shown, that the median overall survival was 17 months compared to only 13 months with paclicarbo. So around 1 year with paclicarbo, 1.5 years with paclicarbo and bevacizumab. So could we do better? Of course, there was an unmet need. We could do better. We need some better drugs, and that is where the rationale came for the use of immunotherapy. So why? So these patients have predominantly HPV driven tumors. HPV positivity leads to overexpression of PDL1. PDL1 positivity leads to that we can use immunotherapy in this subset of patients. So this is the preliminary basic science which we are looking, that yes, 70% of these patients, they are found to be PDL1 expression positive also, compared to HPV negative species, specimen, which are 43% positivity for PDL1. So there is definitely a good rationale that yes, PDL1 is expressed in high numbers. So we can target PDL1, we can target PD1, we can target CTLA4 for these patients. So that was the rationale for use of immunotherapy in these patients. So this is the target which we are looking for. Okay. So then comes to the data about second line. So before we come to the front line therapy, in the second line, not great I would say, some responses, some partial responses, some not many complete responses. So this is a single arm study in the second line after progression on chemotherapy. Can you change from there? I'm having lot of difficulty. Yes. So when I say change, you can please change it. Fine. So with this, this was a study, phase 2 study, keynote 158. Again, you will see only with single agent pembrolizumab in the second line, the overall responses are not that great. Around 14 to 15% is something which we get. Next slide. And then with this, there was an accelerated approval from the FDA that yes, you can use pembrolizumab in the subsequent line after progression on chemotherapy. Next. And then we have some data with dual blockade, that is nivolumab plus ipilimumab responses. Similarly, with different doses of nivolumab and ipilimumab, you get a response of around 25% to 30%. And this also shows that yes, immunotherapy definitely has a role after progression on chemotherapy. Next. So this study shows that yes, you can use either single agent pembrolizumab or you can use a combination of PD-1 inhibitors with CTLA inhibitors, and you can get some responses after progression on chemotherapy. Next. Then we come to the study which we are going to be predominantly highlighting today. So we saw that with bevacizumab paclitaxel, we have an overall survival of around 17 months. So this study, that is the keynote 826 study, tried to find out whether you can combine immunotherapy along with this backbone of paclitaxel or cisplatin with or without curative treatment. They did not have any prior systemic therapy. They were fit patients. They were stratified by metastatic disease at diagnosis, or PDL1 CPS of less than equal to 1, 1 to less than 10 or more than equal to 10, and bevacizumab use. So bevacizumab was not mandatory. They could use bevacizumab, so it was plus or minus. So they were randomized to up to 2 years of pembrolizumab along with this chemotherapy for 6 cycles, and then plus and minus of bevacizumab versus placebo plus this backbone, with a primary endpoint which was dual, that is progression free survival as well as overall survival. Next. So this is the patient predisposition. Predominantly patients, 3/4 of the patients were squamous cell carcinoma, and then there were also some others, like you can see here that almost 90% of the patients do have expression of PDL1. So it is more than 1 in almost 90% of the patient. Only 10% of the patients would say PDL1 expression is less than 1. And then there were patients who had also received radiotherapy, chemoradiotherapy. Some of them had received surgery also. The other interesting thing to see here is that 1/3 of the patients were de novo metastasis or stage 4 disease. Otherwise, most of them were like unresectable recurrent disease. So one in 3 patients were stage 4 disease. So bevacizumab use, as you can see here, not all patients had got, but almost 60% of the patients in either arm got bevacizumab. So 30% to 40% patient did not receive any bevacizumab. Next slide. And this is the interim result in PDL1 CPS more than 1 population, improvement in PFS, and the overall survival here in this subgroup. You have seen the placebo chemo bev arm performed 16, which is historically good. They had 17 months in 2017, and now it is 16 months, so it has not underperformed definitely the standard arm. And the pembro arm, the median overall survival had not reached. Next slide. And this was the all-comer population. Again, in the all-comer population, the median PFS had improved, and the median OS has now gone to 24%. So the PDL1 CPS 1 patients, the median OS was not reached, and now this is the updated data, and we see that the 16.5 months in the chemo plus bev arm, and in the pembro arm it was almost 24, 2 years, significant 8 months clinically relevant improvement in overall survival. Next slide. And this was the protocol specified final, again in the CPS more than equal to 1 patients, and here the median OS was 16 versus 28. So 28 months was the best response, best overall survival we see in this subset of patients. Next slide. So significant difference has been kept after a longer follow-up. So the curves are almost separating, not like they are merging with each other. They are maintaining nicely the gap. So showing that yes, whatever benefit, incremental benefit we have got, we have maintained it at a longer follow-up. Next slide. Next slide. And this was the for all comer population, that was for CPS more than 1, for all comers again. So 16.8 months versus 26 months. Next slide. And this was for the PDL1 CPS more than 10. So again, good improvement, almost 30 months is the median. So with incremental benefit you see in survival with the incremental in the PDL1 CPS levels, that is what we can see. And here we can see that whether when we have gone for the stratification variables, we have found that almost across all PDL1, but predominantly the benefit is seen in the PDL1 more than 1, that is 1 to less than 10 or more than 10. The number of patients with PDL1 less than 1, as I said, is hardly 10%. So difficult to comment about these results in this subset of patients, but at least with PDL1 any expression that is more than 1, this regimen definitely scores over the other. Similarly, bevacizumab, whether they have used or not used. So suppose you do not want to use bevacizumab, your patients, probably paclitaxel would be reasonable enough if there are some contraindications for bevacizumab, as this forest plot shows. Then there is something very intriguing here, is that if there is metastatic disease at diagnosis, somehow you can see if there is non-metastatic disease, maybe localized disease, probably gets more benefit. But as these subgroups have not been pre-specified for significance, we cannot comment on this. We can just say that from this we can see most of your patients are likely to benefit. More benefit would be seen in those patients probably who are having a PDL1 expression. Next slide. So this is the PFS. Next. CPS more than 1. Next. All comer, again improvement in PFS. Next. CPS more than 10 again. Next. So subgroup similar analysis, PFS analysis, that was OS. This is progression free survival. Next. And response rates. So with response rates are reasonable, 50% versus 70%. So almost lot of patients will get benefit from this regimen. Significant responses if you want to use this regimen also. Next slide. So adverse events, of course, we use this 4-drug regimen, and so of course we do expect that there would be toxicity. So grade more than equal to 3, but we have seen that it is possible to manage this toxicity. So no new signals is all we can see. And next slide. So this was the pembrolizumab patients with persistent. This was the subgroup analysis which was done. Next. So subgroup analysis, squamous, non-squamous. So non-squamous also stand to benefit. So which are difficult to treat subsets, these adenocarcinomas and all, they do also have benefit with this regimen. Next. 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 Carboplatin, cisplatin, whether you use cisplatin or carboplatin, we almost do not use cisplatin, we use carboplatin, but if you use cisplatin also, not a problem, should benefit. Next. Next. So then coming to the population which bevacizumab and no bevacizumab, we discussed this. So irrespective of whether you are using bevacizumab or no bevacizumab, you stand to benefit from this regimen. Next slide. Next slide. Then prior chemoradiation. So patient has received prior chemoradiation, no chemoradiation, likely to benefit. Next. Next. So PFS and OS, if you see across almost irrespective of the stratification which you use, you stand to benefit with this regimen in terms of progression free survival as an OS. So there is nothing much to choose that yes, I will not give in these patients and I will probably give in these patients, probably other than PDL1 CPS. So not much to choose. Next slide. Next. Next. So this was the study pembrolizumab 1 trial, which clearly shows that there is definite role for immunotherapy in this subset of population. We have made a significant stride by using immunotherapy in this population with a significant improvement in survival. Does this stand good for atezolizumab? Somehow atezolizumab, we say that If you want to fail somewhere, you use atezolizumab. That is what is the dictum in the immunotherapy circle. So atezolizumab somehow has not made much inroads, but this is a really good data for atezolizumab. Except SCC and small cell lung cancer, of course. Otherwise, atezolizumab somehow has failed. Anyways, no offense. But in this trial, at least we see that atezolizumab in combination with platinum doublet and bevacizumab, very similar study, very similar indication, and let us see the results. Next slide. This is published in the Lancet. So same sort of population. So you combine here atezolizumab, but here bevacizumab was mandatory. In the other arm, 60% patients had received. Here bevacizumab was mandatory with chemotherapy as well as immunotherapy. Primary here endpoint was PFS. There the primary endpoint was PFS and OS. Here also dual, of course, primary PFS OS. Next slide. Next. Yes, next. So this is the patient predisposition, not much to see. Next. Same, next slide. So squamous, adeno, then unresectable. Similarly, metastatic disease. So almost most patients had prior radiotherapy, had pelvic disease, recurrent persistent disease. Next slide. Not much to choose between here. So this is again very good curve. You can see clearly separating curves. Median PFS 13.7, somehow numerically better, and the Bev arm has in fact performed better than the historic arm. Next slide. Next slide. This was statistically significant. So here we can see 17 months was the trial with that. Probably the population is bit different here, and therefore the median OS in this is 22.8 months, and still there is a 10 months increment in overall survival with addition of atezolizumab. So 32 months was quite significant. So definitely again this is some drug which we can use in our practice with solid evidence. Next slide. Next. Okay, so this is the OS we are seeing already. So this is comparing with that other slide we see here. Next slide. Next. Okay, so safety, not much to choose between here. Some immune related adverse events, otherwise similar. Next. So this is based on these results. We can see here that in patients with recurrent or metastatic disease, the preferred regimen would be, as I said, PD-L1 negative patients somehow, although numbers were less, the benefit or the magnitude of benefit was mainly in the PD-L1 positive patients in the pembrolizumab arm. So irrespective of PD-L1, if you want to use, probably atezolizumab is something which was showing benefit. We don't have the data for that PD-L1 positive negative, but if it is PD-L1 positive, probably pembrolizumab, cisplatin, Pacli plus bevacizumab would be the regimen of choice with any PD-L1 expression, but we should give these options to our patients. Next slide. That's all. Thank you. Thanks for the patient hearing.
Thank you so much, Dr. Mishra, for your wonderful presentation. And we'll just give us 1 second, which is setting it up. And We shall welcome back Dr. Ghanshyam Biswas for the second half of this talk today.
So actually Shivam from my side is collecting the questions, and at the end, so me, Saurabh and anybody in the crowd, so who can answer, so that can be answered. So okay. So moving away from metastatic disease to locally advanced disease, and so concurrent chemoradiation, whether to give 30 milligram per meter square, whether to give 100 milligram per meter square 3 weekly. So that debate is not there in cervical cancer. It is mandatory that 40 milligram per meter square. Now, whether you give 5 cycles or 6 cycles, so in all the trials, 5 was mandatory and the 6th was left for the physicians to decide. Now, there was an extended cisplatin. So after concurrent CTRT, so whether giving additional cisplatin will benefit, so that trial showed that it has failed. So there is no role of an extended cisplatin. So what happens if you have a patient, because 1 out of 5 patients in a cervical cancer, especially for stage 2 and stage 3, you might have a patient who requires a renal or ureteric stenting for obstructive uropathy. So whether neoadjuvant giving some form of systemic therapy will benefit, or add something to the standard, that is chemotherapy, radiotherapy. So coming to neoadjuvant setting, so where the URTC trial and the Japanese group of trial, so what they did in the URTC trial, so they gave few cycles of neoadjuvant followed by surgery. As compared to chemoradiotherapy, you can see the hazards was more than a 1. So Japanese group, so that was again neoadjuvant on, all these were phase 3 trials. So neoadjuvant chemotherapy with surgery followed by only surgery. Again, you can see, so there was no benefit of adding neoadjuvant to this group of patients, stage 2 and stage 3 up to stage 4A. And astonishingly, so which has not been seen in many other cancers like breast, lung, or even the GI cancers. So the higher rates of surgical complications. So Dr. Minal Kanti is here, our surgeon is here. So 25% grade 3, grade 4 morbidity, while if you have used neoadjuvant in a cervical cancer. So higher rates of, so not only you are doing disharm, but you are probably incurring mortality and morbidity by giving a neoadjuvant. So neoadjuvant is out of the box, and as I said, even adjuvant is out of the box. So these were, the first one had a 50 patients, and you can see both these trials, the phase 2 trials, they have used gemcitabine as a backbone. Today, if you have to use any systemic chemotherapy for a metastatic disease, so taxanes are the first choice, and if the patient has progressed, then probably gemcitabine based, and then there are XYZ options, what Dr. Saurabh has already shown. So all these phase 2 showed a response rate and toxicity. You can see the overall response rate, which included a CR and PR and even a stable disease. But the grade 3-4 toxicity was 20% with neoadjuvant, and after using a CCRT, so went up to 44%. So they have used a day 1, day 8 schedule of GemCis before they have moved to the standard therapies. Again, PFS. So if you see the second trial, which has more than 100 patients, 3-year PFS was 40% versus 60% in the CCRT arm. So we are doing more harm. So the third was a phase 4 study, which had a 150, and this time they have used taxanes, and so 2 cycles followed by CCRT 2 weeks after the completion of chemotherapy. So there was a gap of 2 weeks following the induction chemotherapy. So they looked at a complete response rate, which was 88% versus 67%. And I don't know if you have seen a p-value of 0.000. The best p-values are seen in breast cancers and probably ALK tumors, where if you see a lorlatinib and alectinib, but this p-value is probably all 0. Then came interlace, which was a 500 odd patients. So this was a phase 3 which started using a weekly carbo at AUC2 and Pacli at 80 milligram per meter square, followed by CCRT. So here, so the third one, which was a phase 4, so you are starting CCRT 2 weeks later. But here, so you finished 6 weeks of therapy the very next week. So you are starting the radiotherapy. So there is no gap here. And the PFS and OS, you can see the primary endpoint, this was primary, co-primary endpoint. So there were positive for PFS and OS. So coming to the interlace trial design, so these were all newly diagnosed. So they have used, because we'll see that interlace has used FIGO 208, whereas the other trial have used FIGO 2014. Stages 1B1, node positive, 1B2, 2, 3B, 4A. So 4B is taken as a metastatic disease. So they have included predominantly squamous, because 15% of the patients will be adenosquamous. They have not included another, that is small cell one. So no nodes above aortic bifurcation on imaging, because aortic, para-aortic nodes are taken into a loco-regional nodes. So beyond para-aortic, so these are systemic disease or metastatic disease. Fit for chemotherapy and radical radiation with adequate renal functions. No prior pelvic RT even. So the randomization, so these 500 patients were randomized to, so carboplatin, which was AUC2, and paclitaxel 80 milligram per meter square for 6 weeks. From week 7, so interlace, the very next week we have starting on radiation. So while radiation, so you have moved to a cisplatin again. So if given Pacli carbo, but with radiation, so you are giving the standard therapy of cisplatin 40 milligram per meter square for 5 weeks. And the 6th week, and the 6th week, it was up to the PI to decide. So the external build radiotherapy was up to 50 gray in 20 to 28 fractions, and brachytherapy to a dose of 78 gray to a point A. So overall treatment, should be completed with 50 days. So it was 6 days to 7 months, 1 week was allowed for an unseen, like we had a COVID time we have seen. So 56 days was allowed. Otherwise, in a routine, so it should be completed. So cervical, while you are treating cervical cancer, so duration is important besides the cisplatin, the dose. So duration is important. So there are situations when there is a machine breakdown, then the patient has a 2-week break or 1-week break. So this has a survival disadvantage. Second, if you have not corrected the anemia in cervical cancers, so that is also a detrimental factor in survival. So these are two important things when you're treating cervical cancers, putting on concurrent CTRT, which has not been, we can say, substantiated in a head and neck cancer, where again CCRT is a modality of treatment. So while follow-up, so 3 monthly for 2 years and then 6 monthly for 5 years. It was stratified to site, stage, nodal status. So 3D conformal or IMRT, tumor size, squamous cell, which is 85 to 90%, and another non-squamous, where we know that non-squamous, especially adenocarcinoma, small cell, those small cell was not included, so they are more aggressive. But you try to treat them similar way, except the small cell. So there was a primary, co-primary endpoint with PFS and OS, and all other being the secondary endpoint. So you can see the most patients, so all well balanced between the chemoradiotherapy arm versus the experimental arm, so 1:1, with stage 2B being the predominant about 70% and rest 30%. And if you see 1B1 node positive is just only a one patient. So these were numerically, but they have included that one. So 1B1 with node positive is rare to be seen. But so 1B1 to stage 4A and predominant, so 2B 70%. And that is what we see in a clinical practice. Squamous 80% versus 15% and 85% non-squamous. Nodal status was almost 60% were node negative, and the largest tumor size was 5 centimeter. So now look at 64 months, that is 5 years. So we had, as I said, so there were co-primary endpoints. So looking at the PFS, so the experimental arm versus the standard arm, at 3 years PFS of 75 versus 72, at 5 years 73 versus 64, with a hazards of 0.65 and significant p-value. So another co-primary endpoint was overall survival at 5 years. You can see hazards of 0.61, p-value 0.04, and 3 years OS and 5 years OS has been mentioned here. So adverse events at any point of time, so definitely once you are adding induction chemotherapy, some sort of systemic therapy and the alopecia, we know that cisplatin doesn't cause much of alopecia, but the taxane does cause, so that's why you will see lots of neuropathy, and because it was only a 6 weeks, so again neuropathy was not significant, but definitely alopecia and other toxicity was seen as compared to CCRT. So what worked for interlace? The dose and schedule, the patient profile, or any other point. So now we see. So we have already seen a similar slide from Dr. Saurabh, that locally advanced cervical, the rationale for use of immune checkpoint inhibitors in cervical cancer, and I think so he has well explained about the PD-1, the PD-L1, the HPV and disease per se, how this interaction goes on. So now coming to all the checkpoint inhibitors that has been tried in cervical cancers. So I'll mainly focus on the keynote A18, then CALA, keynote 826 and the BITC, which was last two, which were used in a persistent and recurrent metastasis settings that Dr. Saurabh has already dealt with. So these two are minus. So keynote A18 is a high risk locally advanced cervical cancer. So what do you mean by locally advanced high risk patients? So now if you go back to what happened in a breast cancers in an adjuvant setting, so when CDK4/6 was used in a, so the first trial, monarchy, that is abemaciclib. So you looked at more than 4 nodes. If it is more than 3 nodes, then you need to have a grade 3 tumor, more than 5 centimeter tumor. Similar is the story here. And that's why probably palbociclib failed, though the Natalie has a different group of patients. So similar is the situation. If you have to incorporate, you have to understand the keynote A18 just for a broad understanding. So that took a high risk patients, whereas CALA was for the Aam Janta patient, you can see. So that will make you understand. So the pembrolizumab, quick heal bond karo. So the pembrolizumab, the keynote A18 for the high risk, whereas durvalumab, we'll see. So the population of in the A18 is 1B, 2 to 2B with node positive, and then 3 and 4A. Whereas in the CALA trial, you can see with the durvalumab trial, so 1B to 4A, any nodal status. So any cancer node positive is always a high risk. So demographics, so these are relatively younger patients, and 60% patients were in stage 3 and 4A in keynote trial, whereas stage 3 and stage 4A was 75% in the Kala trial, whereas keynote CPS more than equal to 1, that is PDL1. So the design was 1:1, double blind phase 3, which was for the both the trials. The pembrolizumab in the keynote trial was a standard 200 milligram every 3 weekly for 5 doses with CCRT. But after that, the maintenance was 6 weekly for 15 doses. So 6 weekly, so patient has to come 1.5 महीने के बाद एक बार आने का है for 15. So that is equivalent to 30 cycles. So 30 plus 5, 35. Because whenever you say about immunotherapy, so 2 years is the benchmark. So these 5, 3 weekly, and then 15, 6 weekly. So the patients, so on a maintenance, and we have seen, so patients on a pemetrexed maintenance, patient on a trastuzumab maintenance. So the ease and difficulty of patient coming every 3 weeks versus patient who has to come less frequently, so significantly difference, and the compliance improves with that. Though you are using the same drug but at a higher dose, so 200 versus 400, 3 weekly versus 6 weekly. So the endpoint for a keynote was PFS and OS, and you know that for any trial, and that too if you are dealing with the curative intent, OS is so important. So the CALA looked at the primary endpoint was PFS. Quick hill new piso asche. So now we have seen the similar slide from Dr. Saurabh. So my focus will be on the left hand side. Rest 2 has been dealt by Dr. Saurabh. So now that keynote A18, so the pembro plus chemoradiotherapy for high risk locally advanced cervical cancers, overall survival from the randomized double blind phase 3 keynote A18. So this included ultimately, though there were 1600 patients, but significant number of screen failed. Normally, so I am doing trials, but 20% and beyond 30% at times is not acceptable. But this trial had a huge number of screen failure, and that's how ultimately 1000 odd, that was 1060 patients were included. So as I said that interlace, it was a FIGO 2008 and this was FIGO 2014. Stage 1B to 2B node positive disease, or 3A and 4A, either node for 3 and 4A node positive or node negative, RECIST 1.1 and treatment naive patients. The stratification factors were EBRT type. So I was asking my colleague Swaraj today that what is BMT. So IMRT versus velocity modulated arc treatment versus non-IMRT and non-BMT. So does it make difference or not? So as I understood that, so we'll see in the subsequent slide that it is not making a difference. So one is IMRT is not a continuous beam, so but whereas BMT has a continuous beam. Stage at screening, stage 1B to 2B versus stage 3 and stage 4. So one was node positive and this was node positive or negative. So planned at a radiation from less than 70 gray versus more than 70 gray. So the experimental arm was cisplatin 40 milligram per meter square every weekly with EBRT followed by brachytherapy plus pembrolizumab 200 milligram 3 weekly for 5 cycles, and these patients on a response on continuation of the treatment went on to maintenance for 2 years of pembrolizumab. Here as I said 400 every 6 weekly for 15 cycles, which is equivalent to 30 cycles, with a 200 dose, where the standard arm has a placebo. So these were radiation quality assurance. So this was important because we know that, so this is one disease so where radiation is so important, and these were the minimal acceptable cumulative radiation dose that has to be delivered, and the quality of brachytherapy that has to be important. So besides that, as I said, so number of days is also important. You need to finish by 50 days. So 1 week further was allowed for an unforeseen days. So the treatment dispositions, as I said, so 1600 patients, but around 32% screen fail, so it was quite high, and ultimately 1060, 176 sites and 30 countries, including many in the Asian population. And this is how on the experimental arm, you can see ultimately 16% patients remained on treatment till this publication of 2024 ESMO. 40% completed treatment, means 2 years of treatment, and 40% discontinued treatment, out of which mostly are due to disease progression, either radiological or clinical. The second group is the toxicity, for which the patient were discontinued. The same thing was also in the experiment in the standard arm. So now look at the baseline characteristic. So as I said, so relatively younger patients for this disease, so less than 50 years. Asians were almost 30%. And if you see, so PDL1 more than 1, so 95%. So now MSD supports us doing these tests, otherwise it costs almost 12,000, 14,000. We are thankful that for all head and neck cancers, all G junction and all cervical cancers, they do it free. And I've been using that, so that is a great help. So now that brings us whether we should do a PDL1 or not, because if 95% patients are positive, and probably a very small, less than 5% actually a lower PDL1, and that is how the trial, as Saurabh said, that though that was in a metastatic setting, so should it do or not? I'm not sure. So only 30% patients were symptomatic, and many of patients were absolutely good performance status, and again 80% were squamous cell versus less than 20% were non-squamous. So 1B to 2B with node positive was 44%, and then 56% were stage 3 and stage 4 with or without nodes. Here you can see that lymph node involvement, pelvic nodes positive 60%. And most important is to note the para-aortic nodes were seen in almost 2.6%. And both pelvic and para-aortic nodes was 20%, and no positive pelvic or para-aortic node was seen in 15%. So IMRT or BMAT was almost 90% patients. Somebody who did not receive both of these was less than 10%. Less than 70 gray was again a very handful patients, so most of them received more than 70 gray. So now a progression-free survival at 18 months, so 1.5 years. So hazards of 0.7 with a p-value significant. At 24 months, we can see 68% versus 57%, favoring the experimental arm. The same PFS at 2.5 years, so that is at 30 months, hazards maintaining the same at 0.68, and at 36 months you can see 70% versus 57%. So both these at 1.5 years on the left hand side and 2.5 years on the right hand side, you can see all these patients are getting benefited. So you can see all the diamonds are in favor of the experimental arm, which had a pembrolizumab. The other primary endpoint was overall survival at 1.5 years. You can see hazards of 0.6, significant p-value. So 83% versus 75%. What is happening at 2.5 years? So that was also, this was at 2.5 years. So overall survival, so probably elderly patients, if you look at the OS, so that was not happening in the PFS. So elderly patients who are more than 65 years, because you have seen that these patients, that the majority pool were younger patients. So there were only 22 patients where you can see the hazards were more than one probably. So this was the only negative part, that elderly patients. So should we, so what should we infer from that? So that house has to decide. The rest you can see all the parameters, it was favoring the pembro arm. Secondary endpoint were overall response rate and a response duration. So if you see the pembro arm in blue and light green versus the brown and the pink one, so the delta was around 4% in favor of the experimental arm. If you look at the rate of response duration, so you can see overall duration of response in the pembro arm 77.2 versus, so 10% difference. So now all cause adverse events, treatment related adverse events and immune mediated adverse events. So immune mediated adverse events were seen definitely in pembro arm. I don't know how 17% was seen also in the placebo arm. And but if you see, there were side effects because CCRT in head and neck or in cervical cancer, so that comes with toxicities, but at the cost, because we are looking at a survival or a cure. So if you look at the lead to death was less than 1% and leading to treatment discontinuation. So lead to discontinuation any treatment was 20% in the pembro arm, which was also 15% in the standard arm. So if you compare both, so not much difference. To conclude, A118, so pembro combined with modern radiotherapy techniques with CCRT in a standard dose cisplatin, and then continuing pembro maintenance 400 at 6 weekly, so had a statistically significant and clinically meaningful improvement in the PFS and OS versus the standard arm. With a newly diagnosed, previously untreated, high risk locally advanced cervical cancers with FIGO 2014, stage 1B to 2B with node positive, and 3 and 4A with or without node positive. The safety profile of all PD1 today we know that we have been using across all indications are manageable. So 20% patients will have some of the endocrine, so we need to watch out for endocrine, skin toxicity, and certain rare toxicities we have been seen. So these data supports pembro plus CCRT as the new standard of care for patients newly diagnosed, previously untreated, high risk, locally advanced cervical cancer as an appropriate control arm in future clinical trials. So this was mentioned. So different East Asian, Japan and China. So probably if you look at China did better in terms of the PFS in the China population was 0.31 versus Japan 0.6. We have seen the similar in a lung cancer where Japan patient did well than rest of the Asians. So it is said that it is very difficult to kill a Japanese lung cancer patients because you can see a mutations EGFR ALK up to 60%. Then bring us to the PDL1 study, that was durvalumab in a similar setting, that was a Kala study. So that was PD1 and this is PDL1. So primary locally advanced cervical cancer 1B to 2B or 3A to 4, any nodal status. So their node has to be positive for the early ones. So RECIST, good performance status. So that was over 1000 patients, this was 700 patients. So similar concurrent chemoradiotherapy with durvalumab up to 24 months. And the primary endpoint was PFS, was there was a co-primary endpoint of OS and PFS. Here OS and other ORR and duration of response, including safety and quality of life, were the secondary endpoints. So with the PDL1 in the Kala trial, the progression-free survival, you can see both the curves, the experimental and the standard arm almost kissing each other. In fact, in the secondary endpoint, overall survival almost they are kissing each other. So the Kala phase 3 trial did not achieve statistical significance even for the primary endpoint of improving PFS. So leave aside the OS. So that brings us, why did one succeed and one fail? So is it the inclusion criteria? And we have been debating on PDL1 versus PD1. So are these drugs different? Though we see toxicity wise less in the PDL1 as compared to PD1, but if you see, so many of these tumors, like we see, so like in the renal cell cancers in the adjuvant setting, so where Pembro worked and the many other did not work. So this debate has been continuing for now quite few years. So that shows us the Kala versus the Keynote 18. So PDL1 versus PD1 populations were different. So high risk in the Keynote A18, whereas this was an Aam Janta in the population in the Kala. So it was a negative trial in fact, because PFS benefit was not there as the primary endpoint, not even the secondary endpoint, whereas we have seen a primary, co-primary endpoint benefit is there and 33% mortality risk reduction. Sample size, it was bigger in the Keynote A18. So 1060 patients versus 700 patients. So as I already said, the broader patient cohort in the Kala as compared to A18. So we have used cisplatin in A18, whereas Kala we have also allowed carboplatin. So is that the difference? We don't know. If you look at the compliance, as I said, once you have completed the CCRT, so patient has to come 6 weekly versus 4 weekly, because durvalumab will be given at 4 weekly, whereas 6 weekly. So is that the patient follow-up is important. Keynote 18 versus Interlace. We can see the Keynote used a figure 2014, this was figure 2008. 55% patients had stage 3 and stage 4A, whereas this had a lesser, that is 26% to stage 3 and stage 4A. 61% had pelvic node positive in the Keynote A18, whereas 43% pelvic lymph node positive in the Interlace. And so these were the major differences between chemotherapy based treatment and the immunotherapy based treatment. So we saw the difference between Keynote A18 and the Interlace. We saw the Keynote 818 and the Kala. So one positive trial versus the negative trial, and these were two positive trials in their own setting. So I'm leaving this. To conclude, so now in a patient with a deep pocket, so tomorrow you go to your clinic and see a similar patient. So whether you are giving a concurrent RT and CT, that is GOG 120, which has been there for 3.5 decades. So many of us will still give it, because many of us are treating on a government scheme, so where this has been there. So would you approach NACT approach Interlace, where you are giving us 6 weeks of weekly Paclitaxel, and that is well under the scheme that is available in our state and nationally. So I think now it's time that we move from GOG to 120 to at least Interlace, because the benefit to the patient has to be given for this dreaded disease. So I think it's time to say goodbye to GOG 120 and at least move to Interlace. If you look at the horizon, then probably Keynote A18 for all our patients in an eligible patient would be the optimum treatment in time to come, when cost should not be a barrier and when it gets reached to the patient. So all these are 3 positive trials. So GOG 120, which has been there for so many years with us. Interlace is the new boy which is making waves, but the The bigger wave is keynote A18. So that is probably will have more follow-up, and the most important for our country will be the cost part. And I thank my colleague Dr. Ranjan and Antara for helping me out. So that was my last slide. Thank you so much. मूव होने दे तो दिखा क्वेश्चन क्या है मेरा मोबाइल वहाँ पर रखा है दे मोबाइल देता এটা ক্লোজ করো মোট লাস্ট স্লাইডটা বার করো मेरा है ना So now we come to the question and answer session. So there is a question from Dr. Sangeeta Lodha. So what is your opinion on single dose mass vaccination, which WHO says? I think so that's a very pertinent question when we have good number of females in the crowd. So anybody has an answer to this? So what is your take on, so now the established dose of HPV vaccine for 9 to 14 years is 0 and 6. For 15 to 25, it is 0, 1 and 6. And I'll tell you a story. So when my daughter turned to be 10 years, so I gave the first dose of injection at Spurs. So to her and her elder sister. But I myself forget, and the child forgot purposefully because she did not want to take the injection. So I could recollect after a year, so I again vaccinated her. So for that reason I went and searched. So the most important problem for any vaccination, and that too when we are looking at a cure, you are looking at a probably a prophylactic treatment for a disease which is so dreadful, is the main obstacle is not the cost, not the availability, because now the problem is of vaccine hesitancy. So that came up. So few years back, so there was a study, so which actually collected all not patients, so these were all healthy individuals. So they collected all the data, and they found that quite a significant girls did not come for the second dose. And when they were longitudinally followed up, so they were doing absolutely good. So that brought us that probably one dose vaccination is good enough, though the guideline says that it has to be 2 doses for 9 to 14 and 3 doses for 15 to 25. But so vaccine hesitancy is a bigger problem. So if somebody has taken at least one dose, then it is that also has a good amount of antibodies with them. So there is a question from Divya Januja. What is your take on circulating tumor cell guided immunotherapy for cervical cancer? How can you close the gap between clinical utility of circulating tumor cells in clinic? So that's an important question. So that is what we have started doing in few cancers. So one of the glaring example is colorectal cancers. So especially for stage 2, when are you going to treat this patient or not? So normally you decide on the high risk factors versus non-high risk factors. We treat on the basis of MSI high versus MSI stable, and then how long to give chemotherapy, 3 months versus 6 months. So many of these depends on if somebody can follow up with a circulating DNA. So I think so that's a great thing in cervical cancers, in a colorectal cancer. So there are many other cancers where this is being tried. So we do it in even metastatic colorectal cancers and people have started doing in triple negative breast cancers. So at this moment for cervical cancer, this is more of an experiment, But probably, so as we are moving into more and more um, better therapeutic armamentarium, so I think so that will be there on the horizon sometime from now. So that brings us to the last, so to concluding vote of thanks. So
I have a question.
please.
So, as we are talking about the cancer scenario, hello, am I audible? Okay. Okay, good evening, sir. Actually, we are seeing that PD-1 in many patients, like 95 of the percent of the patients are positive. So, what about the CTLA4? Like, is there any study regarding that where they see that the cancer patients are positive or negative in CTLA4 immune checkpoint?
So like the PDL1, so normally we don't estimate the CTLA. So at this moment, the CTLA4 that's available with us for commercial use is ipilimumab, and the combination of the PDA1 and the and the CTLA4, so Nivo EP. So that is one regimen that has worked in across all disease subset and all hard to treat diseases. Right? So we have moved from a higher dose of ipilimumab, which had a toxicity, to a lower dose of now 1 milligram. So, but we don't estimate like the PDL, that a PDL1 we do at either the TPS. Most of us for lung cancer we use TPS. Rest of the cancers like with cervical cancers, GI cancers, head and neck cancer, we have been used CPS. So I don't know if somebody has used CTLA4 or not. So if you have any idea from the medical team. So at this moment we have not been doing that. So there are three WHO tried for using an immunotherapy. So one is the regular PDL1. So either you take CPS or TPS. The second is MSI. It is high versus stable, right? And the third is a TMB. So TMB for a paraffin, you will have to have more than 10, if it is liquid more than 15. But after these three triad, there are many patients who are not going to respond in spite of this. Then people started looking at beyond these three triad. So in colorectal cancers, now besides this, stool microbiome is getting importance. And there are so many other RNA based, but stool microbiome, especially for GI cancers, and that is becoming important. So there are three triads, as I said, triad. So beyond that, there is something that is working out. So one of them is a stool microbiome. So thank you.
So, sir, as we are blocking these particular immune checkpoints, nowadays CAR T cells are getting developed. So, can't we just completely create a blockade to these particular checkpoints in order to
So
have
like,
good
so my friend,
prognosis?
my colleague, Dr. Vijay Patil is working on solid tumors CAR T cell. So at this point of time, CAR T cell has not made a dent in solid tumors. So cervical cancers or many other lung cancers. So now for the CAR T cells, liquid tumors, ALL, NHL, multiple myeloma. So absolutely, so this is one of the treatments where if you have failed multiply, you have failed on stem cell transplant, then CAR T cell. But as of now, probably CAR T cell, people are looking at different. So as of now, CAR T cell is not the standard of therapy. The people are spending around 2 crores, but as of now, that is not a standard of treatment for solid tumors, especially CAR T in considering CAR T cell in solid tumors.
Thank you so much.
Sir, I have a last question. Using this monoclonal antibody against the PDL1 and PD1, some people develop some autoimmune disorder or some immune
Yes,
sensitivity.
yes.
So, what your hypothesis told about this? Some people said
This is
develop.
not a hypothesis. So this is there. So I have a patient who was on Keytruda. So he was an army jawan. He had a very bad RCC, recovered after 2 years. So So the keynote, so pembro and axitinib. This patient went on to CR. So this patient, so now 2 years off therapy. He has completely, so he was in ICU on a ventilator, and now 2 years off immunotherapy and also the oral TK axitinib on a 3 monthly follow-up. So few months back he followed up, losing weight, and then continuous vomiting. So CT scans were done, scopies were done, so nothing came out, but the patient was symptomatic, losing weight and vomiting. So now, so on a long term or on a patients who are on any of these PD-1 and especially or a PDL-1, then you look at endocrine. So this patient on evaluation with an endocrinologist at KIMS found out to be having a hypophysitis, so ACTH lower, and now with steroids, this patient is absolutely normal now. So autoimmune disease, so you are exploiting the immune mechanism of a patient's microenvironment, and you are ought to get some autoimmune phenomenons, including starting with all itis, so keratitis, then hepatitis, colitis, pneumonitis, so you can have thyroiditis, so all this. So you are developing. So this is going to happen in 1 out of 5 or 1 out of 6 patients, and mind it, so most of them are not grade 4 and 5. So when you talk about immune related adverse events, so the importance is it a grade 1, 2, 3 or 4, 5. So if it is 1, 2, 3, then it's acceptable. Only on 4 and 5, then we are going to discontinue the treatment and patients will be on steroids. So a few of the last concluding slides, so who, what, when, so we have been discussing for last 1.5 hours. And this was the slide we have seen. On the left hand side, the summary of what I talked about locally advanced. On the right hand side is what Dr. Saurav talked about. So adding checkpoint inhibitors with concurrent CTRT in locally advanced. So PDL-1 durvalumab in Kala versus pembrolizumab, that is PD-1 in keynote A18, which has a positive PFS and OS benefit. And the last slide on primary metastatic or recurrent. So it is all about PDL-1 CPS more than 1 EPS, then combine chemotherapy with or without bevacizumab and pembrolizumab. If somebody has PDL-1 less, either you can use Atijo, we have seen that trial, or you can combine chemotherapy with bevacizumab. So there is a role for second line ADC, that is testosterone vedotin, and for later lines there are good number of cytotoxic chemotherapy with a response rate from 10 to 20%. Now that brings us in locally advanced and a metastatic disease. So is cisplatin the king? So am I enough? So that's not the story. So now we are moving from single agent cisplatin to a combination. So small step today, big chances for tomorrow. So change is the end result for all true learning. And I thank Indian Society of Oncology, MSD. And lastly, the Mice Idea team, represented by Shibam and his team. So lastly, saluting our real heroes, what we saw in last few days with Indo-Pak conflict. Thank you so much before you join the webinar.
Thank you so much, sir. I just want to say the 3 points. One is that today's session we literally discussed from hydroxyurea to the ADCs and even the CAR-Ts, which probably will have the very important role in future for solid tumors. We really hope so. And second, also the entire focus was on how we differentiate different regimens that we have and how we optimum do go for a patient selection in the Indian infrastructure, And last but not the least, because we are a vaccine organization, and really happy with that, because cervical cancer is one of the cancer which can be prevented by vaccination, and it's again very very critical for our patient. I sincerely want to thank Dr. Ghansham sir. I mean, sir. I mean, the context setting to the conclusion, so comprehensive, and definitely bringing your own experience, especially when you highlighted about the pembrolizumab side effect, which is also very very important to identify as early as possible. Also want to thank Dr. Saurav, who actually left because of some personal commitment. And last but not the least, the entire audience who are sitting here, as well as online, for the patient listening and the interactive session. Thank you so much. Please feel free to give us a feedback. I mean, we really look forward to it. Thank you.